Okay, well, I think we'll get started because we have Victor Chow coming and he's going to have to leave early. So hopefully if we get to some questions at the end, it'd be nice to have him here. I'd just like to thank everyone for coming. Victoria, Prince George, you can see some people, and that's awesome. I'd also like to acknowledge a few people that helped me with this talk. Victor Chow, for one, and also Mike Carter in Kelowna. This is basically a talk that's going to highlight a few issues in infertility, particularly male factor infertility. It's not going to be a general overview, and the topic is so broad that it basically precludes me from doing that. The highlights of this talk is going to include a brief talk on oxidative stress and infertility, which is one of the sort of upcoming topics. Infertility genetics, which I think is one of the most interesting things that have been developed over the past 20 years or so. And then just briefly talking about workup, because that could be a lengthy talk in itself, and sort of a primer on assisted reproductive technologies at the end. The definition, as we know, of male factor infertility is basically a male factor involved in 1 year of unprotected sex without pregnancy. Overall, about 15% of couples do struggle with this problem, and about half of the time there's a male factor, and it's probably, as an isolated problem, more commonly a female issue, but combined issues make up a total of 50% with male factor involvement. In the United States right now, there's estimated to be 8 million couples with infertility, which is about 4 times as many people as there is veterans of the Iraq War at the current time. In about 10% of people that present to your office with male factor infertility, there could be an underlying disease there that you're going to want to identify because it could be potentially life-threatening. And as the AUA and American Society for Reproductive Medicine have outlined, evaluation of male and female partners should occur in parallel. Just a very basic look at how you work up a male for infertility. You want to do a history and physical, and these have long lists of things that you need to identify as risk factors. You want to look at semen analysis, hormones, and then there's a lengthy list of other tests that you can consider as well. And then you go to conservative or surgical therapy after that. Female evaluations are focused more on ovulation and ovarian reserve in the more mature females. Anatomy is also an issue there. You want to rule out any sort of tubal problems. Etiology of male factor infertility. Well, this list is way longer than this, but these are sort of the big ones. Varicocele, you can see, is a big issue. Idiopathic represents about 1 out of every 4 people. You won't come to some sort of diagnosis with them. Genetics, back in this paper in 1978, it was estimated to be about 10%, which is pretty close. I'd say it's closer to about 15% of patients now are going to present with genetic problems. Amongst the list of great topics in infertility, there's a lot of highlights and a lot of things that I'd love to give grand rounds on, but unfortunately time does not allow. So oxidative stress, the first topic I'm going to sort of highlight here, is it's an interesting story from my perspective as a medical problem because it has a very unexpected ending. It's sort of intuitive that if you're going to be smoking or be exposed to pesticides or pollution, that this is going to stress your ability to make sperm, your ability for sperm to be vital and live. And diabetes, cancer, varicoceles, everything has been linked to this oxidative stress. And these are basically free radical oxygen molecules that are wearing down the sperm. This leads to a number of things, and these have all been actually identified in vitro. There's altered acrosome reactions in these sperm that are stressed. They've got worse motility, and interestingly enough, they've got a large amount of DNA damage and fragmentation, and it can also lead to apoptotic reactions, which are actually normal in a lot of sperm. As if someone's abstinent, the sperm do cycle and they go through apoptotic phases, but you can also induce this by creating oxidative stress. Now, the interesting thing about this story is that this all seems intuitive, right? So you've identified oxidative stress as being a problem, so you recommend stop smoking, reduce your exposures, try and get more lycopenes in your diet, or vitamin E, selenium, all the different antioxidant molecules that we're familiar with. And this is not only in people, but also in vitro fertilization therapies. They're using a lot of antioxidants in order to preserve the embryos. But the real interesting thing to me is that, that all seems very straightforward. But from this has come a theory that DNA fragmentation, or oxidative stress leading to DNA fragmentation, can predict outcome of in vitro therapies. So if you look at a test known as the sperm chromatin structure assay, which is a PCR test that basically looks for disorganized DNA or DNA fragmentation, likely a result of oxidation, you can predict a miscarriage. And you can also predict a 16 times increased risk or increased success with intrauterine insemination. And that's huge, because if you can get away with intrauterine insemination, you can avoid doing ICSI or one of the more advanced reproductive technologies, which run about $10,000 for one cycle, which has about a 30 to 40% success rate depending on maternal age. So this could actually be a huge breakthrough in infertility testing. Moving on to genetics, it's important for us to know about genetics because there's always a risk of disease transmission to the child, and that's foremost the concern, aside from the risk to their existing health. And you also want to try and help yourself make a diagnosis and prognosticate their ability to conceive. ICSI has pretty much changed everything when it comes to this, because no longer do you actually have to have motile sperm to conceive. But with that, it also brings up a whole new level of sort of ethical dilemmas, as well as we're sort of going against natural selection here, which has been hypothesized as a process of devolution. And for your viewing pleasure, I've sort of put together a series of slides on what the world might be like if it devolved. The good news is that not all people believe in evolution to begin with. Just to highlight some of these things. The United States is second from the bottom there, with about a less than 30% belief in evolution. Canada is not a heck of a lot better, around 50%. I'd just like to point out that my homeland of Iceland is definitely at the highest, at around 80%. Yeah, I think that you could probably say that every birth in Iceland might be a genetic experiment to begin with, so they're probably pretty attuned with the ideas. It's not listed here, no, but I looked it up, and yeah, exactly. We all know this is not true because we're headed in one direction overall. But if it was to be true, a lot of things would change. Hockey players, game shows. There's a whole bunch of things that would probably be a lot different in this world. Boss-employee relations could be significantly compromised. This necessarily wouldn't change so much. I think the scariest one, though, when you really look at things, would be this one. Okay, fun's over. Okay, so going back to genetic considerations. Genetic problems can be classified a number of ways, but probably the most straightforward one would be abnormalities of number or structure of the genes, partial chromosome deletions, and specific gene defects. There's a whole whack of genetic issues that have been identified over the past few years even, and this list continues to get longer as more and more genes and more diseases get actually identified. You can see here cystic fibrosis in the top left, and the bottom right, Y microdeletions, Up here, you're going to have your Kallmann syndrome, and down here, your sperm immotility diseases and Cardiganers. If you look overall at people presenting to your infertility clinic, you're going to have about 6% of them that have, these numbers are from Europe, and it's got to be higher than this, but over time they've identified more and more, but about 6% of your patients are going to have some chromosomal abnormality, and this is versus about 0.4% in the general population. About 4% will have sex chromosome abnormalities compared to 0.14% in the general population, and autosomal is still about 8 times the general population. Now, abnormalities in number, I'm just going to blow through some of this genetic stuff. It is interesting, but time's going to be of the essence here. So polyploidy is basically 23N, and N can be any number. So polyploidy, normally sperm are haploid, or they have half the number of normal chromosomes. Polyploidy, you can have 46, you can have 4 times, 6 times, however many numbers. And aneuploidy is basically one of these chromosomes being in a different number. You can detect this using FISH, and it exists in about 0.1 to 0.2% of normal people for disomy, 0.1 for diploidy, and it does carry a risk of miscarriage and fetal aneuploidy. You can see down at the bottom here, this is an example of a FISH study where you can see the bottom right, there's both an X and a Y chromosome. These ones are both normal. And this would likely lead to Klinefelter syndrome. This, as you can probably tell, is an example of Klinefelter syndrome, karyotype here, where you can actually see 2 X chromosomes and a single Y chromosome. This is the most frequent sex chromosome abnormality, representing about 66% of karyotypic abnormalities. 1 in 1,000 phenotypically male patients will have Klinefelters. And as we know, small firm testes with minimal germ cells, female hair distribution and scanty body hair, and long arms and legs as well because of a delayed epiphyseal plate closure because of low testosterone levels. Germ cell presence varies. You can detect this if you're doing IVF and you're worried about it. You can detect it with FISH studies on the embryo. The mosaics will have actually a pretty low rate of having diploid sperm. However, if you are a pure Klinefelters, only about 25% will have a normal haploid sperm. Here's an example, and if you do identify these embryos, they should not be implanted. And just to keep in mind that if you do see a Klinefelter's patient in the infertility clinic, they do need lifelong follow-up for androgen deficiency. This is courtesy of Victor. This is basically what you get as a report back when you send a karyotype, and this patient, interestingly, has actually 2 X chromosomes. However, there's been a translocation of the SRY region, the sex-determining region, of the male onto one of the X chromosomes. So this is known as XX male syndrome. There's other X-linked genetic disorders. Kallmann syndrome is the most common one, and multiple genes have recently been identified that put patients at risk for this. There's also autosomal dominant and recessive forms. And there's a wide spectrum of presentations in these patients, but primarily gonadotropic hypogonadism is the big problem, and it can be treated. Androgen insensitivity is another X-linked infertility disorder with a wide spectrum, and there's also rare XP deletions that have been described in infertile males. Why microdeletions is a huge topic, and this is something that was first sort of hypothesized in 1976, but at that time there was no ICSI, so it wasn't really that clinically relevant. It was identified as the AZF or Azoospermia factor gene at that time, and was further characterized in 1995 by Rijo, and was known as the deleted Azoospermia gene, or the DAS gene. Since that time, it's gotten even more characterized, and I'll show you a picture here to just sort of show how it's rapidly ballooning into something. but it does cause testicular failure, Sertoli cell only, and severe oligospermia. And this has also been prognosticated by the portion of these genes which are non-overlapping genes, so they can all be individually tested for. AZF-A, Sertoli cell only. AZF-B, more likely to be maturation arrest. AZF-C is probably the best, where you have only hypospermatogenesis, and D is a variable one, but confers disordered spermatogenesis. And these have all been sort of mapped out along the Y chromosome. And further on the right side, you can see that they've been further characterized and named. What's the clinical relevance of this? Well, it's both diagnostic for your patients when they present with infertility. It's prognostic as to whether or not testes biopsy is going to reveal sperm, and whether or not they're going to be able to undergo ICSI. And also, they're going to pass this on to all their male offspring, so it's good for them to know that. Cystic fibrosis. So about 1 to 2% of people that present with infertility are going to have congenital bilateral agenesis of the vas, which in 1969 meant you're hooped, but currently ICSI, IVF, all viable options for people with cystic fibrosis. It's carried on the CFTR genes carried on the 7th chromosome. Rates in Europe and Canada are about 1 in 25 for carrier status, about 1 in 2,500 for actual clinical CF. There's been tons of mutations that have been identified for this, and there are some more particular ones that are more popular, but the list just gets longer and longer. Testing for this usually will detect about 90% of them, though, and that in itself has developed significantly. Most common genetic defect is known as the delta F508, or a phenylalanine amino acid at the 508th position of the CFTR gene. There's a huge variation in the presentation of these patients, and as you can see, if you have clinical CF, you have about a 95% chance of not having a VAS. Overall, 1 to 2% of men. Occasionally, they'll have 2 mutations on the same gene, and unilateral agenesis of the VAS is a different story, because 43% of these patients will carry a CF mutation, and maybe more will have it. They just can't identify genetically, but a lot of these patients will actually have mesonephric duct anomalies and also carry renal anomalies with this, and it's totally a different ballgame from CF. Epididymal obstruction can be seen in about half the people with CFTR. Just to mention, congenital bilateral absence of the vas is a clinical diagnosis. These patients don't have palpable vas, and we should be able to make this diagnosis without any aids. Certainly should never go to biopsy. It can be the vas. It can basically be any Wolffian structure, so the distal 2/3 of the vas all the way up to and including the seminal vesicle and ejaculatory ducts. Basically, if you walk in and you have congenital absence of the vas, and you had a pregnant wife, your chance that this kid is going to have CF is about 1 in 150. Now, I'm not going to get into this too much, because if you identify congenital bilateral absence of the vas, you should have the partner screened as well in order to avoid any sort of homozygous offspring. Renal anomalies are common with both, but renal agenesis is most common without CFTR, not to get those confused. And what does it really mean? Well, risk of clinically significant CF in the man is present with CBAVD, so they should be screened. And also, children need to be considered as well. Just going into some of the workup. Now, I'm not going to go through everything here. I'm going to gloss over some stuff, because I want to get through this in time. But basically, what do we need to do? Well, standard history and usually a questionnaire is the best way, because there's a lot of risk factors that it's sort of painful to go through in an office interaction. So the patients can do that on their own. Physical exam is also a lengthy thing. You want to look for sex characteristics. You want to try and palpate a vas, look at testes size, and you want to do 2 or 3 standard semen analyses. Optional evaluations are hormonal, genetic, specialized semen function tests, and imaging studies and testes biopsies. So when do you do this for patients? if a patient's infertile for 1 year, then they've granted themselves a workup. Other things that can do it are basically if they've got risk factors like bilateral cryptorchidism, if there's advanced age in the female or other female risk factors, then you want to screen the male as well, because time may be of the essence. And a bit of a soft one, but if there's a lot of anxiety or they're questioning their fertility period for family planning, it's another indication. Just to quickly mention some common gonadotoxins, there's medications out there, a long list of them. Pesticides has now been identified as creating more and more oxidative stress, so it's something that I encourage people to ask about in clinic. Recreational drugs, anabolic steroids are sort of like birth control pills for men, and smoking has been actually identified to reduce your sperm density, decrease function, and increase DNA fragmentation through oxidative stress. Semen analysis, the WHO criteria have been elucidated, and all of these numbers do actually prognosticate some degree of fertility or what is going to require to be done. I'll show you pictures on that later. Overview of the tests. So there's a number of endocrine tests, but primarily testosterone and FSH are the mainstay of fertility workup. Other tests like prolactin and thyroid hormones need to be considered on an individual basis. Post-ejaculatory urinalysis is important for men, particularly with low semen. Trust ultrasound can be used in the workup for that. And then there's all these really interesting semen and sperm tests that I'm not going to get into, but I'll just mention anti-sperm antibody tests for immunologic infertility, sperm viability tests, and cervical mucus tests. And then there's some tests of the acrosome reaction with the zona-free hamster oocyte test, and computer-aided sperm analysis, which really hasn't shown to help all that much, but can sort of take away the bias between centers if necessary. Workup of low volume, basically you want to distinguish between ejaculatory duct obstruction here and retrograde ejaculation. Primary seminal emission is also in this differential diagnosis, but that should be apparent through history. For retrograde ejaculation, you want to also give them a trial with sympathomimetic agent to see if they can actually antegrade ejaculate. Oops. Sorry. We've got a ways to go, as you might be able to guess here. Oh, okay. I am just glossing over the stuff here. Hormonal evaluations. Basically, this is a pre-testicular, testicular, post-testicular factors. Basically, if it's coming from your pituitary, all your FSH, LH are going to be low. Testosterone will continue to be low in testes failure, but your FSH should be high, and obstruction, all these serum tests should be normal. This is just looking at sort of the spectrum of what you can find on testes biopsy with these patients, Sertoli cell only, where you can see the Sertoli cells sitting there looking for someone to cuddle, but there's no swimmers around. Maturation arrest, you can see some spermatogonia there, and some progression to spermatocytes, but no spermatids. Up top, hypospermatogenesis, you can see some spermatids sitting up there, but they're minimal in number. Genetic screening. So what are you trying to prove? You want to look for karyotypic abnormalities, Y chromosome microdeletions, and cystic fibrosis. This is the mainstay of genetic screening. So patients with oligospermia, usually karyotype and Y microdeletion are reasonable tests to order. With severe oligospermia, the yield of these results will go much higher. CF screens can be considered in oligospermia. Non-obstructive azoospermia, basically karyotype and Y microdeletion, are going to be the mainstay of genetic treatment. Obstructive azoospermia, you want to screen for CF. Genetic diagnoses are a bit of a minefield because you got to make sure patients are educated, because you may uncover a diagnosis that they're not willing to accept, and genetic counseling needs to be employed as well. Karyotypes, you look at peripheral leukocytes. About 7% of people, infertile men, will turn up a problem here, and that yield also goes up with azoospermia. For sex chromosomal aneuploidy, Klinefelter's 2/3 of patients, and this does confer an increased risk in the offspring. Y chromosomal microdeletions are also a spectrum that goes up with more severe azoospermia or oligospermia. This is a PCR test, and it's a non-overlapping region, so they can all be tested for individually with good sensitivity and specificity. Here's an example of a report of a patient, again provided by Victor, and this basically shows AZF-A, B, and C all present, which is a normal study. CF gene mutations on chromosome 7, 66% of people that have CBAVD will have CF, and about 90% of people with CF will have CBAVD. And these numbers are all skewed because of testing for CF as well. And again, the partner becomes the focus after this diagnosis. Here's a report again of a patient that has a rare CF mutation. And it's interesting, a lot of these mutations are associated with secondary mutations that are also being tested for. The location that you're at also confers what kind of CF testing they do normally. So just to summarize, low versus normal volume azoospermia has different workups. CFTR and karyotypic abnormalities have impacts on health, and that needs to be considered. All genetic diagnoses require counseling regarding risk to the offspring, and the partners need to be screened for CBAVD, or the partners need to be screened if you're concerned about CF, or if CBAVD is present, they need to be screened anyway. Can anyone tell me who this is? No? Okay. This is okay, here's a clue. She's born in 1978. It's okay. So it's Louise Brown. She's the first test tube baby, and she recently gave birth and made those test tubes into proud grandparents. Definition of assisted reproductive technologies. It's defined basically as anything that requires manipulation of the gametes or the embryos. Now, IUI is sort of considered in this, although it doesn't really require that manipulation. In vitro fertilization, then micromanipulations, which could be partial zona dissections, subzonal injection of sperm, or ICSI or intracytoplasmic sperm injection. The outcomes are basically measured in a number of ways, but probably the highlight of this is that you want to look for singleton live birth pregnancies per cycle. Multiple births are great, but they do carry higher risks for both the children and for the mother, as well as cost and morbidity. So singleton live births is probably the best measure of whether or not something's successful. There's a sort of gradient as to, if you look at patients that present, what they're going to end up getting. If you've got greater than 40 million sperm, then it's pretty much just time to get busy. Intrauterine insemination can be used for people with about 5 to 40 million sperm, and then less than that, you're going to be on the IVF and the ICSI train. Cervical factors are probably the biggest thing when it comes to IUI indications or intrauterine insemination indications. It's basically to get by the cervix. And this can be good if you've got low sperm quality, because the sperm can be washed and concentrated. Anti-sperm antibodies, again, can avoid the motility issues with that to some degree. And problems with sperm delivery, like hypospadias or impotent men, but you can still obtain a good ejaculate, then IUI is a consideration. You can see how on the right side here, success rates do drop as the female partner gets older. They start at about 12% per cycle, and that's in patients less than 30, and drop accordingly from there. Here's just a schematic, and you can see a long pipette's used. This is done under no sedation, so it is usually pretty quick and inexpensive. In vitro fertilization is a process that involves controlled ovarian stimulation, egg retrieval, in vitro fertilization, and embryo transfers to the uterus. And these are all individual steps that significant progress has been made in over the past few years. This is the only schematic I could find, and it's from Germany. And this is Aufgang, where the eggs are being taken. They're put in a test tube with sperm and basically reimplanted. Eingang here. Oocytes are usually incubated with washed sperm for about 24 hours. And this process can go on for up to 5 days. 3 days seems to be the mainstay of what people are doing. They're transferred to the uterine fungus at that time. And if you transfer them younger, basically you'll end up with fewer. But if you wait too long, you can actually select out embryos that are more specific to the medium than they will be to the actual uterus. So it's a real balancing act between when you take them out of the incubator. Just to sort of back up what I was saying before about the semen analysis parameters actually prognosticating. So here you can see Kruger strict morphology actually does have a significant impact on the percent fertilization with IVF. You can see if you have normal morphology, greater than 14% by strict criteria, you have a greater than 88% chance of fertilizing your eggs with IVF. If it's less than 4%, that drops to 10. So that requires a lot more sperm. ICSI, the process of ICSI basically is crushing the sperm tail to create it, to force it to be immobile, and then inject it through the zona pellucida. And I'm going to show you some pictures of this. You only need one sperm and one egg to do this. So you can imagine how that's changed therapies where usually you need hundreds of thousands or millions of sperm to perform these therapies. You usually do implant 4 to 5 eggs at a given time because the take rate's so low. Pregnancy rates usually about 30 to 40% in women less than 35 years old. This does drop significantly after that. About a 50% of in vitro fertilization includes ICSI today. So there's not a lot of pure in vitro fertilization that's being done, and I can't exactly tell from the literature whether this is a push from financial gain or whether or not it actually makes more sense to do ICSI. I think if there's risk factors such as advanced maternal age, then ICSI is more of a sure thing. You can use sperm from anywhere for ICSI, and there's been no evidence to show that there's any difference if you use epididymal or testicular sperm versus sperm from the vas, that it makes any difference in a large meta-analysis. So here's some pictures. This is actually aspirating the sperm into a pipette. And this is sort of like porn for cell biologists, I think. This is injecting the sperm into the egg. This is a schematic representation. There's also a procedure known as SUSI, which is subzonal insemination, where you put it into the paravidline space. And this has a lower trauma rate to the egg, but the overall fertility rates are actually lower. The future of assisted reproductive technologies involves some really interesting things, in my opinion. Gamete intrafallopian transfer is not really a future thing. This has been done for years, since the 80s, which is basically like IVF, but you're doing a laparoscopic procedure and injecting it directly into the fallopian tube, and the results are not a lot better than with straight IVF. So this procedure has pretty much been abandoned, as it does require an anesthetic. Embryo culture manipulation is something that's heavily being researched right now, and how you can make the cultures more hospitable to embryos and increase the capture rate. Pre-implantation genetic diagnosis, also interesting. I mean, you can basically tell anything about this embryo before it is implanted. So once the cells have divided into about 8 or 16 divisions, you can actually take these cells out and analyze the genetics of them. You can tell whether or not they're male or female. You can tell whether or not they've got Klinefelters or CF or any disease that you want to screen for. Gamete and embryo cryopreservation is another interesting topic, as the ability to freeze eggs is being researched right now. And this would basically confer women that are going for chemotherapy or have some sort of desire to preserve their eggs in the long term. It's difficult to do these days because there's basically a meiotic spindle in every egg, and it's very fragile. So when you freeze it, quite often the eggs become void. Ovarian tissue freezing is another really interesting one, where they've actually had a small series of women that have gone for chemotherapy, and they've donated actual ovarian tissue, and this tissue has been implanted into usually the forearm after the procedure is done, and they've actually conceived children from retrieving eggs from that tissue. So that'll be interesting to follow. Here's just a quick look at embryo transfer. So you can see as the cells multiply, there's an optimal implantation time, sometime between 3 and 5 days here. So indications for IVF and ICSI, there's the only real absolute indication is if you have to use surgically retrieved sperm. There's very rare incidence of pregnancy with intrauterine insemination with vas deferens sperm, but clinically it's not significant. So this sperm usually needs to be managed through ICSI. The relative indications, basically immunological fertility. If there's a lot of anti-sperm antibodies, this gets around that. Failure to conceive with IUI, less than 5 million per ejaculate, poor sperm morphology, and male genetic infertility like Y chromosome or karyotypic abnormalities. And then low motile sperm count as well can lead to ICSI. This is just outside the clinic, the fertility clinic the other day. I realized that there was some advanced maternal age coming in. Complications, just to quickly mention, ovarian torsion. Because I've actually seen women with ovarian problems be referred to urology for stones. And just something to keep in the back of your mind, if you do see a woman in this case and she's been getting fertility treatment, ovarian torsion is much more common as the ovaries get a lot larger and more demanding, and they will torse. So if you do see some woman with lower quadrant pain, keep that in mind. Ovarian hyperstimulation syndrome is a life-threatening condition. It's caused by excessive gonadotropin secretion. It's rare. It's less than 1% of IVF cycles, but you get electrolyte balances, hypovolemia, you can get anasarca, peripheral edema, and then you can get thrombotic events as well. So it can be quite a disaster. Complications, procedure-related, so egg-related retrieval, less than 1% complication rate, and those complications can be a bowel injury, pelvic hematoma or vascular injury, and also pelvic infections or abscess. Procedure associated, the biggest concern is multiple births, as it does carry high morbidity, and about 35% of people that get ICSI will have multiple births, which is somewhat of a concern. These children also do carry a higher risk of learning disabilities and congenital malformations. Imprinting disorders has also been a big concern with ICSI, as the natural selection of genes isn't there, and imprinting disorders like Prader-Willi syndrome or Angelman's or Beckwith all have been shown to be higher. So, I mean, what else is there with these offspring? What are you concerned about? And major birth defects and large meta-analyses of all the literature have not shown to be significantly increased. That being said, they all show very slight increases, but it's not enough to be statistically significant. The risk of sex chromosome anomalies is statistically significant, 0.8 versus 0.2% of the general population, and infertility obviously can be conferred if you're a male offspring of a man with Y microdeletion. Hypospadias, there's conflicting evidence as to whether hypospadias is higher in these populations, but from the literature that I've read, most of the papers do say that it confers a higher risk, and this is thought to be due to the use of progesterone throughout the procedures. And imprinting disorders I also mentioned already. So is this cost effective at all? Well, when you compare it to other fertility treatments, varicocele is a good surgery. I mean, these patients show increased fertility rates approximately 7 or 8 months after the procedure, and it is not cost effective to treat a man with a varicocele through IVF or ICSI. Vasovasostomy versus assisted reproductive technology. Again, vasectomy reversal is cheaper. Even if it's greater than 10 years out from vasectomy, it's still cheaper. and even if there's advanced maternal age, VAS reversal is still cheaper. The caveat to this is that you need to ensure that your patency rates are over 79%, so you do need to control your quality. Just a couple of slides here on sperm retrieval options. It's been a pretty hot topic. Epididymal or testicular sperm, you can aspirate if you have obstructive azoospermia. Testicular sperm extraction or microtesty for non-obstructive azoospermia, and then for primary emission failure, electroejaculation or stimulation. Just a couple of slides on microtesty, which sort of seems to be a more effective way to harvest sperm. This is a look through a microscope here at a testicle, and you can see in the areas, sort of in the upper area here, where things are sort of thready and thin, that likely confers more of a Sertoli cell only histology, whereas here you can see there's one tubule. I don't know how well this is projecting, not very well, but you can see one tubule here that's quite robust, and this is more likely to contain sperm. This is nearly impossible to see without a microscope. Here's just a look at actually trimming these cells compared to the conventional biopsy. They say for conventional biopsies as well, you're cutting through the tunica without really seeing the vessels, and you can actually injure the testicle that way, as well as you're taking a much larger amount of testis, which can confer morbidity. Success rates are pretty good with microtesty, sperm retrieval in about 60%. This is uncontrolled data out of Cornell. Overall pregnancy rate of 32%. And this is for men with non-obstructive azoospermia, so that is pretty darn good. Just to summarize ART, this is my last slide. Intrauterine insemination is the way to go if you have more than 5 million sperm in a semen analysis. IVF is more successful if you're using ICSI, so if there's risk factors there, like advanced maternal age, you want to do both. Some centers now are just routinely doing both. Varicocelectomy and vasovasostomy or vasoepididymostomy are still more cost effective for the patient, and I don't really know if assisted reproductive technology is going to get cheaper to the point where this may come into question, but certainly not at the current time. And microtesty is a good consideration for people with non-obstructive azoospermia to harvest sperm. And that's it.